this video we'll discuss about sialolithiasis. Sialolithiasis are salivary stones, right? So this is important short answer question in oral surgery and medicine also. You have to write definition, etiology, incidence, mechanism of formation of sialolith and composition of salivary stone, clinical features, diagnosis and treatment. By definition, it is the calcified organic masses, right? Calcified organic masses occurring in the excretory duct of the salivary glands. That is the definition. Just organic masses will become calcified. That's all. Under etiology, the etiological factors are mainly divided into two types. The first one is factors favoring salivary retention, like irregularities in the duct system, and local inflammation, dehydration, and drugs like anticholinergics and diuretics, right? And second factor is salivary composition. If there is calcium saturation, that is levels of calcium are high in the saliva. Otherwise, crystallization inhibitors deficiency. That means in normal saliva, we have the phytate that will act as hydroxyapatite crystallization inhibitors, thereby decreasing the calculi formation. If there is deficiency of phytate, then it will lead to the sialolithiasis formation. These are the two main important factors. The other factors include bacterial infection, right? Otherwise, smoking. Smoking decreases the antimicrobial activity in the saliva, right? So there is bacterial proliferation and bacterial infection, bacterial like sialidinitis that will lead to the sialolithiasis, and hyperparathyroidism. Because in hyperparathyroidism there is hypercalcemia that will lead to the sialolithiasis. If there is high dietary calcium intake, another factor. If you take calcium in the high levels in the diet, right? That is the etiological factors. Then coming to the incidence, sialolithiasis is more common in the male and more common in the major salivary glands when compared to the small minor salivary glands. Because in major salivary glands, especially in the parotid gland and submandibular gland, there is nerve stimulated salivary secretion. That means if there is nerve stimulation only, the salivary secretion will be more. So at the site of food or site of smell or taste anything, the nerves will get activated and there is salivary secretion. If there is no nerve stimulation, the salivary secretion will be minimal or will be no, right? So because of that factor, there is a period of secretory inactivity. That secretory inactivity will lead to the sialolithiasis, right? And among the major salivary glands, it is more common in the submandibular gland because of the 5 reasons. The first one is tortuous course. That is, there are 2 sharp bends in the Wharton's duct. One at the posterior border of the mylohyoid muscle and one just before the opening into the oral cavity, right? Because of the 2 sharp bends and increased calcium and phosphorus content. And there is dependent position of the submandibular gland and increased mucoid secretion. Because of the increased mucus secretion, the saliva will become viscous. That is less flow, right? There is less flow that will lead to the sialolithiasis. Whereas in the parotid gland, the salivary secretion is almost watery. That is completely serous. Submandibular gland saliva is mixed thing, right? And there is secretory inactivity. I just described it, right? Because of that secretory inactivity, now we'll see the mechanism of formation. Because of that secretory inactivity, there is microcalculi formation in the interglandular ducts, right? That means you can see here the glandular system is one large gland that is called as excretory duct gland, and we have numerous small glands. Those are called as intercalated ducts, small ducts, right? Intercalated ducts are striated ducts, right? So the saliva from the acinar cells, these are connected with the acini, right? and again we have the cells in the acini that will produce the saliva. So saliva produced from here will be collected in the intercalated ducts, right? And all the intercalated ducts will release saliva into the excretory duct, the final duct, right? So excretory duct. So because of this microcalculi formation, the bacterial proliferation will occur, right? Bacteria or food debris from the oral cavity through the ductal opening, they will pass into the duct, right? That means due to the ductal opening, they will pass into the duct, and at that microcalculi formation, they will proliferate, right? And that bacterial infection will produce the inflammation that will lead to the focal obstructive atrophy. There is atrophy of the ductal tissue or intraglandular tissue, right? Because of that focal obstructive atrophy, the microcalculi that is formed is escaped from the salivary flushing or from the antimicrobial activity of the saliva. So because of protection of the microcalculi like this, the bacterial proliferation will be more. Okay? So because of the bacterial proliferation, it will lead to the further inflammation, atrophy and obstruction. That means if there is calculi formation at this region, right? If there is calculi formation at this region, initially it will be small, but as time progresses, it will become more. It will become more, and there is more obstruction to the salivary secretion, right? Because of that obstruction, the ducts will become dilated, and there is salivary pooling, which is rich in the calcium, right? So calcium saturation will occur and calcification will occur, right? That is the mechanism of the sialolithiasis, that is salivary stone formation. That is the mechanism, right? Now we will see about the composition. Basically, composition is divided into organic particles and inorganic things. Organic, we have the cellular debris or glycoproteins or mucopolysaccharides, and inorganic, calcium carbonate or phosphates or hydroxyapatite. This is more important, hydroxyapatite, right? And vitlockite or octacalcium phosphate. Patient suffering from the gout, in the salivary calculi, you can see the uric acid. This is important PG bit, right? In the gout disease, there is uric acid. So basically, the salivary stone, you can divide it into a central core and peripheral lamellae. Central core can be purely organic or it is highly calcified material, right? In this diagram, you can see here, this red colored one is nothing but the central core, and these blue color are nothing but the peripheral lamellae, right? This central core is highly calcified or it is purely organic, and this peripheral lamellae are less calcified. To simply say, central one is highly calcified and peripheral ones are less calcified. That's all. This is about the composition. Then coming to the clinical presentation, the most important clinical presentation is pain and swelling upon eating. When the patient eats or when the patient masticates, there is pain and swelling, because when you eat, salivary production will occur, right? Because of obstruction, salivary pooling occurs within the gland or within the duct. Because the parotid gland is encapsulated, so there is little space to expand, right? That will result in the pain. Most important thing, just you have to remember only one clinical feature, that is pain and intermittent swelling upon eating. Pain and swelling occurs when the patient eats, that's all. If there is partial obstruction, that swelling will slowly decrease. If there is complete obstruction, the swelling will remain somewhat more time, right? And the overlying erythema on the skin and there is enlargement and tenderness of the gland. Generally, often there is enlargement and tenderness of the gland, and suppurative or non-suppurative discharge will be there. Otherwise, fistulae or sinus tract and ulceration will occur in the chronic cases. If there is long-standing salivary calculi, then these features will you see. Right? These are the clinical features. Now we will discuss about the diagnosis. Diagnosis is based on the history. That is, history of pain and swelling upon eating. Right? And you can go for radiographs also, imaging. Occlusal radiographs or anteroposterior radiograph, especially in the case of parotid duct calculi. Then you can go for xylography. Right? Xylography is important question. We will discuss in that in a separate video. In xylography, again we have the conventional and contrast enhanced, right? So ultrasound, CT or CBCT, MRI and xyloendoscopy. Xyloendoscopy is a recent one. In xyloendoscopy, you can go for both diagnostic as well as the interventional xyloendoscopy. Right? You can diagnose the location of the calculi and you can remove the calculi also with the help of xyloendoscopy. Right? So management based on the mainly location of the calculi, size of the calculi, is it fixed or mobile, and number of the calculi present. Right? So basically, sialolithiasis, if the patient is symptomatic, that is acute phase of the sialolithiasis, then in that case you should go for analgesics, antibiotics and hydration therapy. That is increased liquid intake. Right? This after the symptoms subside, then again this case should be treated as the asymptomatic and you should proceed accordingly. This is the algorithm for management of calculi both in the parotid and submandibular glands. Right? So based on imaging, you have already decided the location, size, is it fixed or mobile, or number of calculi. Right? Based on that, I will take parotid duct as the example. Right? So this is the parotid duct. This can be divided into three portions. Submandibular gland duct also can be divided into three portions, right? So here this red colored one is nothing but the mucosa. So this is the ductal orifice or ductal opening. You can see in the buccal mucosa in the maxillary first molar region, right? So this is one part at or near duct orifice, and this is the middle part of the duct, and it is the intraglandular portion of the parotid duct. Right? So based on the location, we will see the treatment options. First, we'll see at or near duct orifice. So in this location, if it is small and mobile, you can go for the milking the gland. Milking the gland is nothing but the massaging the gland. So when you massage, the gland is stimulated, the salivary production is increased. Due to that excess salivary production and flow, any small calculi will be flushed out from the ductal orifices. Right? You can go for moist heat application also, and you can go for silogox medications also like pilocarpine. Again, they will increase the salivary production. With that salivary flow, any small calculi will be flushed out. Right? In this location, at the orifice, if it is large and fixed, in this case you can go for papillotomy. Papillotomy is nothing but the enlarging the ductal orifice. Will make small incision and will enlarge the ductal orifice. With that enlargement, you can remove the stone. This is one variety. Now we will see calculi located at the middle of the duct. Again, in this case, if it is small and mobile, right, you can go for the interventional xyloendoscopy. Xyloendoscopy is nothing but will pass a endoscope that will have a camera at the end. With that endoscope, you can locate the calculi, and you can using other instruments you can remove the calculi also. Right? This is one variety. At the middle of the duct, if it is large, in those cases you should go for transoral sialolithotomy. Right? Transoral sialolithotomy is open surgical procedure. So in the case of parotid duct, you can see in this diagram, this is the maxillary arch, this is the mandibular arch. Right? So left side of the buccal mucosa is retracted laterally. You can now identify the parotid duct opening. Right? below the parotid duct opening, you should make a semilunar incision, right? You should make a semilunar incision for transoral sialolithotomy, right? This is the incision for parotid duct transoral sialolithotomy. In the case of submandibular duct, right, you can make a incision in the floor of the mouth parallel to the submandibular duct, right? So this is about the incision. You can see the step-by-step procedure of the transoral sialolithotomy. You should do it under the LA. You should give the incision as I described just now, right? After incision, you should dissect and identify the duct. Once you identify the duct, you should make a longitudinal incision on the duct, right? Suppose if it is the duct, then you should incise it longitudinally like this. You should not incise it like this, right? So once you incise longitudinally, you can remove the stone, right? After stone removal, you should not suture the duct. If you suture the duct, it will lead to the ductal stenosis and obstruction of the salivary flow. You should leave it as it is. Then debridement should be done and wound closure, right? This flow chart is for both parotid gland transferal sialolithotomy and submandibular duct transferal sialolithotomy also. In some cases, you can go for extracorporeal shock wave lithotripsy also, right? In this case, high energy shock waves are directed at the calculi and it will fragment it. Large calculi will become small pieces so that they can be flushed out, or you can go for sialoendoscopic removal of those small calculi, right? This is one variety. After that, we'll see the third variety, intraglandular duct, that is calculi located in this portion. Again, in this portion, first you have to go for interventional sialoendoscopy and ESWL. These are the options available. If these two options failed, then you should go for open duct exploration. Open duct exploration is nothing but, I will take example as the parotid gland, right? So, based on the external landmarks, you can identify the approximate position of the parotid duct. You can see in this diagram, right? So, from the lower part of the ala of the nose, you should draw a line to the corner of the mouth like this. Lower part of the ala of the nose to the corner of the mouth, right? And you should bisect this line, right? This is the bisecting point of that line. And this point should be connected to the most posterior point of the tragus, right? You can see here, this is the most posterior point of the tragus, like this. You should join these two points, right? Again, after joining these points, right, you should divide this line into three parts, right? You should divide this line into three parts. This middle part will correspond to the parotid duct, right? So approximately on extraoral things, you should identify the position like this. And when you are going for open duct exploration, right, based on these landmarks, you can easily identify the parotid duct at the anterior border of the parotid gland. In the parotidectomy, I have described the incision for gland exposure. You have to take that incision and you should elevate the skin flap. After skin flap elevation, you first detect the parotid duct at the anterior border of the parotid gland, right? So this is the parotid gland, green color one. I have identified the anterior border of parotid gland and I have identified the duct, right? After that, you should follow this duct intraglandular portion and you should slightly open the gland by incising the parotid capsule. You should open the parotid gland, right? And you should identify the intraglandular portion. You can see in this diagram there is dilatation of the intraglandular portion of the duct. That dilatation is produced due to the calculi. So again, you have to make the longitudinal incision and you should remove the skin, you should remove the calculi. After that, you should do the debridement and you should close the parotid capsule, right? After that, you can go for wound closure. That is the procedure for open duct exploration, right? In the case of intraparenchymal duct location, calculi location, that means calculi located within the substance of the gland, right? That means in this case you can go for here. This is the calculi location, right? So in this case also, first you should try for ESWL, that is extracorporeal shock wave lithotripsy, or you can go for interventional xyloendoscopy if possible, right? In case of extracorporeal shock wave lithotripsy, you should go for multiple sittings. That means this should be done at least 3 times before going for gland resection, right? So if these 2 options fail, then you can go for gland resection, that is xyloadenectomy. And there are some other indications also. In the intraparenchymal position, the calculi is large and fixed, or if there are multiple calculi, or if there is fibrosis and recurrent sialolithiasis, that is recurrent gland infection. In those cases, you can go for gland resection, that is xyloadenectomy. Especially in the case of parotid gland, you can go for superficial parotidectomy. In case of submandibular gland, you should do transcervical submandibulectomy. Right? These are the options available, and how, based on the location, how you should go, how you should choose what type of procedure. Right? This is the algorithm. Then complications, I have already described the complications for superficial parotidectomy in the parotidectomy video. In the case of submandibulectomy, you may injure the lingual nerve, right, or hypoglossal nerve, or marginal mandibular branch of facial nerve, right, hematoma, bleeding. All these are the complications. You can write those things, right? So this is all about the sialolithiasis. If you like this video, hit the like button, share the video, subscribe the channel.